Okay, guys, this is your lecture on leading, managing from chapter 40, as well as chapter 41, nursing informatics. I'm just trying to get the screen in view so that we can start. Okay, so we're going to start with leading and managing, which is chapter 40 in your FA Davis. These are the key terms that you should know to help you understand the chapter. These are the chapter objectives that you can get through your FA Davis book as well. So when we talk about leadership, leadership has the ability to influence other people and enable the movement of people towards a common goal. All nurses need to be leaders because remember, we're going to be leading our patients towards that common goal of wellness, as well as leading ancillary staff below us that we might delegate things to. So every nurse needs to be able to have leadership qualities in them. So the tasks of a leader should be to help staff to develop a sense of direction and purpose, build the group's commitment to a common goal, and to face daily challenges that they're going to experience. Some leadership theories that we have, the trait theories say, is a leader born or is a leader made? So have we learned to be intelligent, or are we just naturally able to interact and understand the way people react? Other qualities that were found to be associated with this style of leadership are excellent interpersonal skills, creativity, willingness to take risks. Your behavioral theories are common with what leaders did, with what leader does. Examples of behavioral theories is authoritarian leadership, democratic leadership, laissez-faire leadership, all of which we're going to discuss more on the next slide. We also have task versus relationship theories. Task versus relationship is some leaders are very goal-oriented or task-oriented. So they're not focusing on their interpersonal skills. They are just wanting to get the HCAHPS scores up or get patients to have the best quality of care. And then other that focus on that more relationship aren't really focused on the task at hand, but saying that if we all get along, the job will get done. Our emotional intelligence theories focus on the ability of leaders to manage their emotions and those of their followers. These leaders possess the following traits of empathy, which is able to make emotional connections with others, self-awareness, where they're able to recognize and understand their own emotions, self-management, so they can control their personal emotions, relationship management, which uses self-emotions to successfully interact and manage others. And it's an ability to build trust, respect, and cooperation within the team. We have social awareness, which is accurately assesses and respond to the emotions of others, ability to listen and accurately interpret unspoken emotions. These very often seem like they're a great leader, but people that lead by high emotional intelligence will often leave a void in their absence. Then we have our situational theories, which means that they are going to deal with tasks at hand. There's no proactive, everything is more reactive, which falls into transactional, and transactional leaders are typically Italian style. Transactional theory assumes that people are motivated by reward or punishment. And transactional and then transformational are most commonly seen in nursing. Your transformational is the one that most jobs want their leadership to strive to be. And this is that it's given people a need this sense of a mission, and that it goes beyond interpersonal relationships. And we'll talk about more of that on the next slide. So these are your leadership styles, and your leadership styles kind of correlate with some of the leadership theories. So your autocratic is going to be defined as a top-down approach when it comes to decision making, procedures, and policies within an organization. Their focus is less on collecting input from team members and tends to just make those executive decisions. Then we have our transactional. These are the negative ones. They're defined as control, short-term planning, the reward punishment system. Our bureaucratic relies on a clear chain of command, strict regulation, and conformation by the followers. As the name implies, this leadership style is commonly found in government entities, military, and public organizations. Your charismatic leaders are the ones that have like these great communication skills. They're very persuasive. They have a lot of charm to them. And because of that charismatic behaviors and charm, they're going to be able to connect with people and have that deep connection. These are valuable when we're facing a crisis or struggling to move forward, because they're going to get people to feel good and they have that good emotional intelligence to them. But again, when we talk about those emotional theories, when that leader's gone, a lot of times the people no longer have that motivation to continue on. Your transformational leaders create a vision based on the identified needs and guide their teams towards that unified goal through inspiration and motivation. The main difference between your transformational leadership and other styles that we've covered so far is that this one focuses on changing the system and the processes that aren't working, unlike transactional or bureaucratic leadership, which do not aim to ever change the status quo. Our coaching leadership is defined by collaboration, support, and guidance. Coaching leaders are focused on bringing out the best in their teams by guiding them through goals and obstacles. These are definitely good preceptor and possible mentor types of leaders that you want. When we look at democratic, this is going to be that participative leadership. They're going to be leading multiple people in large decision-making processes. However, there's a lot of downfalls with this type of leadership, especially if you're that in the middle leadership, because if the people below you all vote for, let's say, to wear blue scrubs, but then higher ups say that everybody's going to be in white scrubs, when you come back and tell your followers that they're wearing white, you're going to rapidly lose the buy-in from them, because you led the impression that their vote was going to count. So you just have to be careful if you ever get put in a situation where you're being viewed as democratic and you can't follow through on it, just like politicians in your day-to-day lives. Our collaborative leadership is focused on encouraging people to work together and across functional and organizational boundaries. The purpose of this leadership is to encourage collaboration with other teams and departments and to accomplish shared goals. It's really important if you're ever going into education. Collaborative leadership is definitely a good quality to have. Servant leaderships put their needs and well-being behind their followers. So their followers' needs go first. These type of leaders have that servient approach and mindset to prioritize their organization, their employees, and their communities all above themselves. This is loved by all. However, it can greatly create burnout because this manager is going to sacrifice their family for their job. It can also blur the lines in their personal life. The laissez-faire leadership takes a hands-off approach to leadership. and gives others the freedom to make decisions, while leaders still provide their teams with the resources and tools they need to succeed. They remain largely uninvolved in the day-to-day work. This leadership style you'll commonly find in creative settings such as advertisement agencies or startups due to its encouragement of independent thinking. And then the situational leadership, again, we kind of talked about that already. It's the same as the theory. This person is going to constantly change because they're going to be changing based off what the current organization or their personal individual needs are. So one day they might say, you only have to come in 30 minutes early to huddle, and then they'll start to notice that people are getting out later. So then they'll change it to you have to come in 45 minutes early. And then they'll notice that their bottom line's getting cut because they're getting overtime. So they'll change it back. So situational leaderships definitely can frustrate staff depending on how it's implemented. So again, as I said, all nurses need to be leaders, but not all leaders need to be managers. So talking a little bit about more of a manager is going to be that employee of an organization who has the official power, authority, responsibility for planning, organizing, coordinating, and directing the work of others. So your manager is that higher level person that you should respect. We have management theories that are essentially about the same as the leadership theories. There's scientific management, which is Taylor, who argued that most jobs should be done more efficiently if they were thoroughly analyzed. Given a properly designed task, a sufficient incentive to get the work done, workers would be more productive. For example, Taylor encouraged paying people by the piece, that is, by the number of widgets made rather than by the number of hours worked. This encourages workers to get most work done in the least amount of time. And this theory is seen a lot with your providers at hospitals, where they'll say, if you see X amount of patients within this time period, you'll get this much. And I've known nurse practitioners that have worked by that. That's not something that you're typically going to see in the bedside aspect of nursing. Other management theories is the human relations oriented management. So work will motivate people. Managers believe that work itself can be motivating, that people want to do their job well, and they will work hard to help their managers provide a supportive atmosphere. And then again, we have that servant leadership, which is going to put everybody above themselves. So your qualities of a manager, what should you as a manager, if you were going to be a manager, what should you expect out of a manager, right? Any manager should have leadership. So they should have those people skills. And other leadership qualities are at the core skills that nurses need to function as a manager, like clinical expertise. If a nurse manager is to help others develop their skills and evaluate how well they have done, they need to be certain about their own clinical expertise. It's not necessary or even possible to know everything about every profession on the team's nose, but it's important to be able to assess the effectiveness of the work in terms of patient outcomes. And then every manager should also have a business sense. Nurse managers need to be concerned about the bottom line, which is cost of the providing care, especially in comparison with the benefit received from that of the care. In other words, nurse managers need to be able to analyze how much time was spent to provide the given amount of care to the patient and how effective that patient care has been. How much would be paid to the institution for the care delivered, and who will pay it? Will it come from private insurance, government, or the patient directly? These are complex tasks that require knowledge of budgeting, staffing, and measurement of patient outcomes, most of which is beyond the scope of this textbook. So some activities of an effective manager, the interpersonal networking managers must clearly articulate the nurse's role and value to the institution. They need to be able to do conflict negotiation and resolution, employee development. This includes providing continuing learning and upgrading employee skills. Advocacy managers must advocate for supporting staff to upper level management. Rewards and punishments. Examples include salary increases, time off and praise, maybe some coaching towards the goal that the employee should do better through learning. Decisional employee evaluations, including conducting formal performance appraisals. Resource allocation, like budgeting and how to use available funds wisely. Hiring, evaluating, and terminating employees. Planning for future changes in budgets or patient populations. Job analysis and redesign to make the unit run as efficiently as possible. And unit-based decisions like staffing policies and space utilization. Their informational spoken person, the manager relies on information from administration to the staff members and speaks to administration on behalf of the staff members. Monitoring, managers monitor the activities of their units or departments. So the number of patients seen, the total length of stay, as well as the staff, absenteeisms, the budget, should be the money spent, and public relations. Nurse managers share information with patients, staff members, and employees regarding new developments in healthcare and policy changes. So you want to become a leader or a manager, right? All of your goals should be that you're going to be a qualified leader. Some of you might want to look into eventually becoming management. We can identify our skills. The first would be possibly using the SWOT analysis, which is strength, weakness, opportunities, and threats. These are planned, borrowed from corporate world. They can guide you through an analysis of your own internal strengths and weaknesses and reveal external opportunities and threats that may help or hinder your leadership or management skills. You can use SOAR analysis, which can analyze any type of situation and create a plan to achieve personal and professional goals. This model, and we can use it for inquiry, imagination, innovation, and aspiration to focus on strengths, opportunities, aspirations, and results. We could work with a preceptor, someone with more experience who provides practical teaching and guidance for a student or new employee. And we can work with a mentor, which is going to be somebody who's more experienced, who provides a career development assistance. They'll be your coach, they'll sponsor you for advancement, they'll provide challenging assignments, they'll protect their proteges from adversity, and they'll promote positive visibility for you. Mentors provide guidance to new students or graduates as they continue in their profession. They offer constructive examples of role model to novice. Mentors can also fulfill psychosocial roles such as personal support, friendship, acceptance, role modeling, and counseling. So these are the skills of the desired job candidate. So if you were going to be filling out a resume, highlighting some of these would be important, like critical thinking, analytical skills, leadership abilities. You're very organized, you're self-disciplined, you work well in a team, you want to work hard, you're motivated. All of that stuff are good things to highlight on the job. And then we talk about preceptors versus mentors. So everybody is going to have a preceptor. And a preceptor needs to be an experienced nurse who's going to be assigned to you as a new staff member, but they may or may not become your mentor. Your mentor is also going to be experienced, but they're going to become your role model. They're going to provide guidance to you, and they're going to fulfill that psychosocial role that we talked about on the prior slide. Your mentor and your mentee responsibilities. So as a mentor, if you're looking at somebody to be your mentor, they should definitely demonstrate excellent communication and listening skills. They should show sensitivity to the needs of the nurses, the patients in the workplace. They should encourage your excellence. They should share and provide counsel to you. They should show you good decision-making skills. They should demonstrate an understanding of the power and politics of the hospital or location that you're working at. And they should also demonstrate trustworthiness to you. If you find a mentor, as the mentee, you have responsibilities to them. The responsibilities that you have to your mentor would be to demonstrate an eagerness to learn. You want to use the feedback that they give you to modify your behaviors. You want to demonstrate flexibility and an ability to change. You want to be open to the relationship with the mentor. And you want to move towards independence. Challenges that any leadership may face, right? So understanding followership. Followership is the willingness to work with others towards a goal. If a unit has a good leader, they're going to have a buy-in from their staff, and therefore they will have followership. Everyone works together in harmony towards that goal. If you have poor leadership, or you don't seem like you're a fair leader, you're not going to get that buy-in from the staff, and therefore you are not going to have followership. When we talk about economic climate is greatly impacted by things within the environment, lack of resources. Resources can be both physical things like masks, gowns, and it can also be things like financial backing and losing government fundings, and politics change and you lose those outreach clinics. So now you have more patients coming in. COVID definitely showed us a devastating economic climate change, and it also affected our labor market. So when we talk about our labor market, that's kind of that grass is greener, so people leave trying to get more money, right? Because if UT gives everybody a $2 raise, then all the nurses in the community say, well, if UT can pay an extra $2 an hour, then why can't Covenant pay an extra $2 an hour? And if it doesn't happen within the time that staff feel, they'll go elsewhere so that they can go to UT and get that $2 an hour. When we had COVID, and the economic climate really changed and the government was giving huge stipends, there were hospitals across the country that made the labor market such an incentive that a lot of hospitals lost their regular staff due to that labor market change, because people were able to get contracts for huge funds that other hospitals couldn't match. Some leadership management concepts. The first would be power. So how do we get the power? How do we keep the power? When we speak about power and leadership, this is the ability to influence others despite those that we are leading's resistance to succumb to our power. We get our powers through our position. So somebody who's in authority, like a chief nursing office, their power is derived from the location in the organization's hierarchy. Person at the top has the most power. Referent power talks about that informal power that's created through a relationship with people within the organization. So you might not be the chief nursing officer. He might not be the CNO, but the CNO might be your best friend. So even though you might be a staff nurse, you have referent power from her to possibly influence other people within the organization. Reward power. This is the ability of an individual to control or allocate incentives. So promotions, salary increases, recognitions, or benefits. Some hospitals put in staff level recognition policies where if you feel your coworker who's lateral in level of power has done a good job, you can recognize them. And that helps build camaraderie among staff members. Expertise is knowledge is power, right? So the person who's experienced on the unit, who's got really strong analytical skills, is deemed critical to the organization because of their knowledge. And you get that when you have potentially longevity with an organization. You've been there for so many years, and because you've been there, everybody knows that you're aware of all the policies, and therefore you have that power from that knowledge. And then coercion. So coercion is that negative one. Coercion is going to be that you have power over others because you're going to threaten them or discipline them. And that's that enforcement. You're going to be the person that's going to enforce standards, policies, procedures through threats. So more sources of your empowerment. How do you, right? What is the empowerment? That is the feeling that we have power to solve problems, take initiatives, and exercise our autonomy. So how can I feel more empowered? We can fulfill our empowerments by self-determination. So you're going to work hard, and because you're going to be a hard worker, you're going to get more power. Meaning, so you care about your work, you enjoy your work, you take it seriously. So that's going to give you a sense of empowerment. Confidence. The more confidence we have, the more self-empowerment we have. And then impact, right? Feeling that people listen to our ideas and that we can make a difference. We can always enhance our sense of empowerment by becoming more confident in our chosen roles. And as we share our knowledge and competence with others, so will our power grow. Communication is another important skill that leaderships need. Our ability to communicate. One model views communication as that circular process that is affected by many factors. Communication in that model has both content and relationship context. This means the activity is continuous, mutually independent, and influenced by the behaviors of each communicator. We need to use active listening to pick up on levels of meaning in the communication. Surface listening or inattention often causes a misinterpretation of the message. A person's attitude also influences what he or she hears and how he or she interprets the message. And you can look back at chapter 21 when we went over therapeutic communications. So as a leader, we're going to have to delegate things. And as a nurse, the ANA has scope and standards of our practice. And we have things that you just as a nurse are not allowed to delegate, like your initial nursing assessment or your follow-up assessments if clinical judgment is going to be indicated. Giving anybody a nursing diagnosis or a nursing concept, any decisions or judgments about the patient outcomes, formulation or approval of your patient plan of care, interventions that require professional nursing knowledge, decisions or skills, or decisions and judgments necessary for evaluation of a patient. And it's really important to remember these because when you hit your practice, This is going to help you keep your license safe and keep your patients safe. When we talk about what we can delegate to an unlicensed assist personnel, we can delegate them to help with activities of daily living, like feeding, drinking, ambulation, grooming, toileting, dressing, assisting the patient with socializing, and taking vital signs. We can have our unlicensed personnel make a clean, safe environment, provide transport for our non-clinical clients. They can order supplies, they can make beds, they can provide message and delivery services, and they can reapply things if you've already done it. So if you've already provided the oxygen and the education behind the oxygen, then the nursing assistant can go in and put the patient back on oxygen. If the patient has not had formal education of that, they cannot do that. Same thing with the incentive spirometer. If you've already completed the education on the incentive spirometer and the patient's demonstrated adequate technique, then the nurse's aide can go back in and assist the patient with the incentive spirometer. But that initial education component has to be done by the nurse, not the unlicensed or not the LPN. So if you're a leader and you need to make change, change comes from unfreezing the comfort zone. The comfort zone is what we all live at. It's our daily process. And if we want to make change, we need to push patients or coworkers out of the comfort zone. And we unfreeze the current zone. When we unfreeze it, we're going to have to overcome resistance. And you typically have two forms of resistance. You can have active resistance, and this is when a patient or coworker or somebody is going to have an aggressive actions or refusals to comply, such as statements like, I'm not going to do it that way. They might give negative emails. They might try to destroy the idea. They might try to get other staff members on board to not have to make the change. This can come depending on your level of leadership at a very large scope or a very small scope. But they will try to encourage other people to join in their resistance. And then you can have people that give passive approaches. And these are the ones that are going to just avoid it. They're going to cancel appointments. They're going to be too busy to show up to staff meetings. They're just going to simply ignore and hope that if they keep their head in the sand, things will just wear out and go back the way that it was. Once you get past the resistance, then you're going to implement your change. So you're going to change whatever characteristic you need to change. Once that change has been integrated, then what we need to do is we need to rephrase it. So that way that becomes the new comfort zone. So when I did my doctoral project and we had to do the change, we started with the way that staff triage their patients, and we had to unfreeze the current way that the emergency room nurses triaged and cared for their patients. We had some team members who very actively resisted, citing the fact that, perhaps I wasn't considered to them as an employee, so they felt they didn't have to listen to me. And then we had passive people who just didn't want to show up to the meetings. But eventually, being that I had management and education's buy-in, we were able to implement the changes. And then once we implemented those changes, we had to completely integrate it so that that was now the new process for how they conducted their triage services. Getting that integral change and rephrasing is a lot of times where changes that have been made fall back because people revert back to their priors very quickly. So don't be surprised if you notice, your manager always starts things and they implement it and we think that it's integrated. And then 2 months later, it goes back to what it was beforehand. It's just kind of the nature of what happens. So conflict, something that all leaders are going to experience, and all people experience, from two kids sitting in the back seat complaining that somebody's looking at them to two physicians fighting about who can manage a patient better. Conflict management is important for all leaders and all managers, because it's truly inevitable that two people at some point are just not going to get along. Um, so we can strive for a win-win, which is going to be the best. Um, we can try some conflict resolution where we're going to identify the problem. We're going to try to generate possible solutions. We're going to evaluate those suggested solutions. We're going to choose the best solution, implement it, and then we're going to move on. And then the last one would be an informal negotiation. And this informal negotiation can get a bit dicey, right? Because you're going to try to clarify the situation, you're going to try to set the stage, conduct the negotiation, continue with the offers and counter offers, and then final agree on a resolution of the conflict. But in class, I've used the example of holidays, right? If you have somebody who says, I can't work Christmas, but I'll work every weekend in all of December and January, a manager might say, you know what, that's a good resolution. We came up with a good negotiation. You're not going to give me one 12-hour day, but you're going to give me 8 12-hour weekends. So they might take it, and that negotiation went well. But now if every employee hears, well, if I work weekends, I don't have to work Christmas, then what do you do as a manager? Because now you made a negotiation, and sometimes then negotiations get pulled back. So just warn you, in professional practice, be cautious with informal negotiations. Um, so you can read over this and just think about what you would want to do if you were a nurse manager and you had this exchange between two staff members. And if you want to pause and just think about it, and the end situation is, best practice would be you need to fully assess this situation. So you would most likely want to be able to take each of them individually in a private location, determine what's going on, and then bring them together and find a resolution. But we definitely need to assess more. So necessary skills that leaders in leadership needs to have. They need the ability to manage time. So it's a good idea to make schedules, make to-do lists, and always prioritize your tasks, and know what's the most important and what might not be important. You might accomplish this by doing daily worksheets. Again, if you do goals, making sure that your goals have priorities to them. You want to make sure that you're very organized in your work, and you want to make sure that if you're delegating work, that you have time to follow up and make sure that what you've delegated has been completed, and completed appropriately. After that, we move on to nursing informatics, which is chapter 41 in your book. These are the key terms that you have on your outline for that. These are your key objectives that are in your book. So what is informatics? Informatics is managing and processing information necessary to make decisions. Nursing informatics is managing and processing information applying to nursing practice, education, and research. Nursing informatics is heavily reliant on computer systems and technologies. So we have our different types of elements of our informatics. So the first would be data, which is going to be your unprocessed numbers, symbols, words, no context behind it. We have information, which is going to be our groupings and processed data. We have knowledge, which is meaningful information created by grouping and compiling of information. And we have wisdom, which is the appropriate use of our knowledge. So being that informatics relies very much on technology, it's very computer driven, and computers, as we know, are electronic devices that have four main functions. And that's going to be that they're going to take information in, so they have an input. Once we put the information in, it's going to process it, then it's going to give us an output, and then finally it's going to store. And you can just think about like when you log onto the computer and you go on to Google, right? If we have a good, strong data processing system, when we put in Google, tell me about, nursing theorists, if you have a strong data processor, it's going to take that input, it's going to process it very rapidly, and then it's going to output a whole bunch of information about all the different nursing theorists that there are. And then if you so close things out, but it's your computer system and you have your own little, Gmail account, when you come back the next day and you start to type again, computer is going to remember that. It's going to store it and it's going to prompt when you start to type, nursing theorists, it's going to bring back that page that you were at the next time. And when we look at patient charts and patient information, again, if we have a good, strong system, we're going to be able to input lots of data, process it, and then be able to pull it out through storage quicker. Computers are great as long as everything's working the way that it's supposed to. However, we know that technology has the ability to be as reliable, but sometimes not reliable, and it can get hacked, and hacking is becoming more frequent. So great as long as they're functioning. When we talk about our different types of electronic communications, we have our internet-based tools, which we can use staffing schedule, patient flow, access to evidence-based references. You can do policies and procedures. All of that is becoming the fast new norm. Many hospitals have developed internal resources. They have special intranet pages and references that are specific to their nursing staff. And again, this is more common than not. When we talk about our electronic emails, many facilities, email is now the primary method for managers to communicate with their staff. Email allows for rapid, simultaneous distribute of information and messages to a large number of recipients. Email and text offer convenience on updates among staff and providers and patients and their families. We have to be very important when we're doing these types of things that we're doing them on secure or encrypted sites. We need to be concise. We need to be aware of our tone. So you don't want to type in all caps because that's going to be you yelling. You don't want to put an exclamation point after everything. You don't want to use jargon. And I caution about using text if it's not a unit-based phone, because if it's your personal phone and something happens, they'll take your phone and audit it. So you need to be cautious of that. When we talk about group distributed lists, this would be your electronic lists for your social networking, blogging, and instant messaging all fall into this bucket. So that would be your social networking bucket. With social networking, you have to be very cautious. Remember, everything you put out into the world is there. You want to make sure that you do not post inappropriate messages or pictures. And you need to be careful about permission, what's allowed and what's not allowed. If you're writing a nursing blog and you want to use your experiences are okay as long as they're broad stroke concepts. It's not okay to give specifics. So I would never start a blog and list the hospital that I worked at, right? Because if I never listed the hospital that I worked at, then nobody could sit back and say, well, that was talking about my grandmother because you were in the nurse at this hospital and my grandmother was there, right? We don't want to give specifics that it was Park West, room 3, 3rd floor, second one across from the map, like stuff like that. It's not good practice. and it can get you into legal issues. And then telehealth. So telehealth is becoming more and more frequent, especially in our rural areas where we can't necessarily in live person meet the accommodations for the people in the community. Telehealth has been used for one physician to treat multiple ICUs. They'll sit in a room and watch tons of monitors and care for multiple patients. There's nurses that now do that because of finding skilled nurses is getting harder and harder. So they'll have one really seasoned ICU nurse who might sit in a monitor room and watch the vital signs, the lab results, the physical patient through a camera. And if they start to notice trends or issues, they'll contact the floor and say, this is what I see, go in and do this. And they'll kind of do that plan of care immediately. If you live in a rural location where there's not a private physician or a hospital, you can, dial up and have a provider see you in your living room. And again, after COVID, this is becoming more frequently seen. Our computer-based tools that are going to help us with our care. So we can talk about CPOE here. Those are those computerized physician order entries. They're going to help prevent our errors. They're going to reduce that transcribing period where the nurse has to take that phone order, get it into the computer system, then the pharmacy has to review it. It goes just directly from the physician to the pharmacy. We have our barcoding medication administration systems. These systems are the ones that we see in hospitals where we have to scan the patient's ID badge, scan the medications, and it prevents us from having errors. And then we also have our smart technologies in our devices. These are your point of care things like your infusion pumps that can have, the entire organization's drugs programmed in so that you're always using them within policy. But remember, as much as all of these are supposed to help prevent errors, it's only as good as the person using the technology. So if the pumps are programmed wrong or the barcoding system isn't programmed correctly, errors can still occur. So we still need to be mindful of what we're doing. We have our simulations, right? So we can do computer-based simulations, and this is going to be doing those interactions before we interact with a live patient. So ACLS, the Advanced Cardiac Life Support, does really great computer simulations where you can kind of click on the little, the little computer icon for, the ambu bag, or you can click on the IV, or you can click on that, and then you click on the patient where you want to place that equipment. And then we also have our high fidelity mannequins, and these are like our sim man that we have in the lab here at the college, where the mannequin can give you vital signs, heart rate, respirations, and it just kind of brings you that one step closer to actually being at the bedside. Of course, barriers to ease would be improper use of the technology, not being able to update the technology, not being able to use it how it's supposed to be. We can talk about health records and informatics too. With our health records, we know that we need to use a standardized language because that's going to facilitate the operations and make it able to be exchanged and understood without losing the meaning of the information. This standardized language is needed also for appropriate reimbursements. Your standardized language uses the same terms to describe clinical conditions in all areas of the health record and allow for easy comparison for interventions and outcomes. And all of this is going to help with their evidence-based practice. And what these health records can do is, if you, like, when I would do chart audits and I was trying to work towards a reduction from door to EKG time, I could actually go into the computer system and I could type a query or a search for chest pain patients in the emergency room. And I would start my search with complaints with chest pain. And it would bring up, 100 people for the month or however many people for the month came in, and they all had chest pain. And then from that point, I could then search how quickly these patients were seen by the doctor. Because then after I did the first filter, then I could do the next filter where I would do door to doctor time. And then I could do door to EKG time. And then we could see how these patients were then treated. And if we were meeting our evidence-based practice, which says that a patient should have an EKG within 10-minute time of arrival. And the patients that fell outside of that 10-minute time of arrival, then we could see what that impact was. Did that negatively affect their care? Did it not impact their care? So that's why we need everything to be put in standard, because if somebody came in with chest pain and they were put in with jaw pain, then when I did my query to do my evidence-based practice search, that patient wouldn't come up. So that's kind of what this is all talking about, is using that standardized language to make sure that we can capture anything to help support that evidence-based practice. So the benefits of the electronic health record, of course, like I just say, it's gonna improve the efficiency, the productivity, and the care. It's gonna reduce redundancies. When we talk about improved accessibility, we have various types of hardware supports that access to patient health information, from standard bedside terminals to wireless laptops and other handheld devices. We have our clinical support tools, our CPOE, which is our kind of physician order entry systems. These are going to help eliminate errors resulting from illegible handwriting, multiple, written orders. It's just more efficient for the nurses as well as for the pharmacy staff to save time. We have privacy, because we can now keep that sensitive patient information and limit it to people who should not be viewing it from seeing it. And then, of course, our public health benefits, because we can get that data out and we can analyze it appropriately to make sure that we're maintaining those evidence-based practices. Again, CPOE, the provider is going to enter the order. It's going to go directly to the pharmacist, and it's going to have that alert system in place to prevent us from having errors. Password education. So remember, all these hospitals, even at school, we have our accounts. Our accounts are password protected. We want to make a complex enough password that it's hard enough for somebody who's hacking it to not get in. So it's not really recommended to use last names, birth dates, or things like that. We want to make sure that we change our password frequently, but not so frequently that we're going to forget it. So every 6 to 12 months is typically what they recommend. We want to keep our password in a area that's not easily accessible. So not written on the back of the computer, the location. And you also want to make sure that we use a combination of letters, numbers, and symbols for maximum protection. Audit trails. This is those little cookies that the organizations have, where as soon as you log in with your password, anywhere that you go in that medical record, it leaves a trail of what you've accessed. So this is how people get in trouble for looking up famous celebrities when they come into the hospital, or when you come in and look up yourself. That actually, for most organizations, will send a flag directly to their auditors to say, so and so access themselves, and that's usually a hard stop that you will potentially get questioned about because you're not allowed to look at your own stuff. You have to follow the HIPAA regulations, even though it's yourself, and you need to sign and follow the policies for how you get your health records appropriately. So when we talk about that further, anytime we need records, either to send to a facility or for us to receive, a patient needs to sign a disclosure form agreeing that it's okay. If a patient is in a network, like say Covenant, you do not need to have them sign a HIPAA release if they were at LeConte last week, because that's going to be in the same computer system. If they were at UT and now they're at LeConte, that's going to need, the person from LeConte sending that consent for disclosure to UT, then UT will process that and send it back. So you just need to know what your facility's requirements are for both sending and receiving patient information. Informatics in the nursing process, nursing practice, is going to help facilitate those evidence-based practices. It's going to help with the new model of decision making. Evidence-based practices use knowledge base from those accumulated best practices, and they can be changed quickly and continuously to find the current best evidence. We need to be able to locate the evidence, evaluate its quality and relevance to the problem, and apply the solution. And again, if you're trying to improve your quality metrics on your unit for CAUTIs and CLABSIs or VAPs or SSIs, if the nurses have charted appropriately the Foley catheter, then you're going to be able to do a quick search for patients in the hospital that have the catheter, and those computer systems should be able to push out all that information, making it easier to track and making it easier to make those changes. So again, how informatics enhances the nursing profession, it's going to reduce those barriers to that evidence-based practice, making it easier to get that data out. It's going to help facilitate our literature searches. It'll provide us with online sources for nursing research, like scholarly articles, and it provides that literature database. And that is the end of this lecture. Thank you.